So I'm just going to continue with my notes. So a spontaneous pneumothorax will push the trachea to the affected side, while a tension pneumothorax will push the trachea to the non-affected side. So just a quick demonstration of this. So a spontaneous, right? What happens is a bleb underneath the visceral pleura will burst, right? It'll spontaneously burst, thus the name. And this usually occurs in smokers, but it'll burst and then create a large hole, right? It'll create a large amount of space. And so you can almost imagine that the trachea will shift towards the space because there's a lot of emptiness there. Over here, a tension pneumothorax is due to, for example, being stabbed, and so the stab causes a one-way valve where atmospheric air will enter and thus crush the normal, or it'll crush the lung. This is the normal lung, and it'll actually shift, right? Because every time air comes in, it'll just keep shifting all the contents to the non-affected side, and that's why the trachea shifts to the non-affected side. So that's spontaneous and tension pneumothoraxes. So next we'll talk about obstructive lung disease. So obstructive lung disease has decreased FEV1 and a decreased FVC, and then overall it has a decreased FEV1 over FVC ratio. So to diagnose it as COPD, it has to be post-bronchodilator and it has to be less than 70. You can use DLCO to tell the difference between COPD and asthma, because both of these will have less than 70, but asthma's DLCO will actually be normal, because in asthma, the only problem is that you have difficulty getting air to the alveoli because it's all being constricted in asthma. The airways are constricted, but once the air does get there, it actually has no problem diffusing. But in COPD, right, and emphysema is a type of COPD, DLCO is low just because there's decreased surface area. Remember that in emphysema, the alveolar walls are destroyed and therefore you have decreased surface area. So in restrictive lung disease, you have decreased FEV1 and decreased FVC, but you actually have a normal FEV1 over FVC ratio. So one key thing to point out here is that this spirometry exam for restrictive is indicative of restrictive lung disease, but is not diagnostic. You would have to do a TLC and RV to confirm this restriction, to confirm the restrictive lung disease. So another point during this module is that there's an increased heart sound for pulmonary arterial hypertension. So it's specifically an increased heart sound for the second heart sound, so that's key to note. And then the screening test is an echocardiogram, but the actual diagnostic test is the right heart catheterization. And so the three criteria to classify it as pulmonary arterial hypertension is greater than 25 for the pressure, and then increased pulmonary vascular resistance, and finally, it has to have normal cardiac filling pressures. So another note during this module is a common cause of clubbing and cyanosis. Both of these, the common causes, are usually lung cancer and pulmonary fibrosis, specifically IPF, which is interstitial pulmonary fibrosis. And for respiration, if you have Chan-Stokes respiration, it's an abnormal pattern of breathing where you have both hypoventilation and hyperventilation, and is usually caused by strokes or drugs. Kussmaul breathing is usually due to metabolic acidosis, usually DKA, which is diabetic ketoacidosis. So eosinophils are usually associated with asthma, except for sudden onset fatal asthma, which is associated with neutrophils. Also, asthma has a strike 3 rule, where if you use your inhaler 3 or more times in a week, or you wake up 3 nights in a month, or you use 3 canisters in a year, you should consider increasing your asthma therapy if you haven't already started. And if a patient scores less than a 19 on their ACT, which is their asthma control test, they should also consider increasing their therapy. So finally, if a patient is suspected of having a PE, for example, if you have hypoxia, chest pain, but you have a normal chest x-ray, these are all indicators of a pulmonary embolism, you should use the modified Wells criteria, and if you get a score greater than 4, you should do a CT angiogram. However, with that being said, you should consider doing alternative treatment if they have a contrast allergy or if they have kidney disease, because these are both contraindications for a CT angiogram. So just to clarify a few things, these are the flow volume loops that you will commonly see when they're talking about normal, obstructive, and restrictive, when they're talking about spirometry. So this is the normal curve. People sometimes call it a sailboat shape, right? So it's kind of like a sailboat. Restrictive spirometry will look like a smaller sailboat. And then the biggest thing about obstructive is that it will have a scooped out shape. So it's kind of like a ski slope. It's kind of scooped out like this, right? So you have your normal sailboat, a smaller sailboat for restrictive, and finally a scooped out shape for obstructive. So finally, the Wells criteria that we were talking about, just in case you had you were suspected of having a PE. So you would first do it if you didn't have any kidney problems or anything, or contrast allergy. So if it's normal, then you don't have a PE. But if it's indeterminate, then you'd still test for a DVT. If it's negative, then you do an angiography or you do serial testing for DVT. If it's positive, treat for PE. And finally, if it's high probability or positive CT, then you'd still treat for PE. So I hope that helped, and thanks for watching.